Hello, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. Welcome to our webinar titled Prior Authorization Industry Landscape. I would like to mention a few logistical items. You will be able to download a copy of today's presentation from the CAQH.org website tomorrow. Also, a copy of the slides and the webinar recording will be emailed to you in the next few days. So to clarify, the slides are not on our website at the moment, but you will receive them shortly. We will save time at the end of today's program to respond to your questions. I encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. We have a lot to cover during this hour. We're happy to have representatives from the American Medical Association and WEDI who will describe industry efforts on prior authorization. Then we will talk about the scope of the CAQH core prior authorization efforts, including going into some detail on the draft Phase 5 operating rules for the 278 transaction. I would like to thank our guest presenters for being with us today. Heather McComas, the Director of Administrative Simplification Initiatives at the American Medical Association, Stephanie Braunschweig, who is the Healthcare Transactions Manager at Athena Health, and Rhonda Starkey, who is the Director of E-Business Services at Harvard Pilgrim Healthcare. It is great to have all of you with us today. Most of you are very familiar with prior authorization, the process, and some of its key challenges. I would like to point out a few basic facts. While PA seeks to manage healthcare utilization by requiring approval for certain medical services and prescriptions, we know that the process is burdensome to all stakeholders. In the commercial market alone, there are at least 150 million PAs submitted and responded to every year. According to the 2017 CAQH Index, full adoption of the standard prior authorization transaction by health plans and providers could result in a savings of $6.84 per transaction for the portions of the PA process included in the 278. I'd also like to point out that there is prominent interest in both the public and private sector to address challenges throughout the PA continuum. On this slide, I'd like to highlight a few points. In 2016, the National Committee for Vital Health Statistics wrote a letter to the Secretary of HHS recommending additional research to understand barriers to improving the PA process, development of additional operating rules to address these barriers, and also encouraging standardization and consistency. In addition, I'd like to point out that there was a hearing late July by the Senate Health Committee called Reducing Healthcare Costs, Decreasing Administrative Spending. During that hearing, PA was a key topic of discussion. And now, let's get started with our first presenter, Heather McComas from the American Medical Association. Welcome, Heather.
Hi, Jessica. Thanks so much for the introduction, and thanks so much to all of you who are joining us this afternoon for this webinar. As Jessica has indicated, prior authorization has sort of become a hot topic in the healthcare industry in the past couple of years. And from our perspective at the AMA, a lot of this has to do with the burdens posed by this process on both physicians and patients. So I'll start off today by talking about the problem from the physician point of view and also the patient point of view, and then kind of broadening our lens to looking at how different stakeholder groups are coming together to address this issue. Go ahead to the next slide, please. So we're going over some AMA research today that tries to quantify the burden of prior authorization on physicians and patients, and also presenting some patient stories that we've recently gathered from our new grassroots website, and then also discuss some of the collaborative industry efforts that AMA has been involved with to help reform this process so everyone is not burdened by it, from providers to patients to health plans, all included. Go ahead to the next slide. Thank you. And you can go to the next one. So we hear all the time at the AMA from our physician members about their concerns and their frustrations with the prior authorization process. But we thought it was important to try to gather some hard numbers and some quantitative data to actually put some definition around the amount of resources that prior authorization is consuming in physician practices today, and also to help characterize the impact of this process on patient care. So we conducted a web-based survey of 1,000 practicing physicians in December of 2017. Those 1,000 physicians were 40% primary care physicians and 60% specialists. You can go to the next slide. And the first thing we wanted to get at in the survey, when this first slide shows you a statistic that Jessica mentioned in one of her previous slides, but, is prior authorization, what are the typical wait times today for prior authorization responses from health plans? And 64% of our surveyed physicians indicated they wait at least one business day for prior authorization response from a plan, and 30% reported waiting at least 3 business days for a response. And this is time that patients are waiting for care that they need. And go to the next slide. And it's not surprising, based on these wait times reported by our surveyed physicians, that 92% of physicians indicated that prior authorization can at least sometimes lead to delays in patient care. And then this, I think, starts to build an important story, because none of us like to wait for anything in our, fast-paced world, and that's annoying. But it's more than just waiting, and it's more than just being annoyed. This actually has an impact on patients and their care and their health. So we hear that care is being delayed from physicians. And if you go to the next slide, we asked our physicians their perceptions of prior authorization's impact on treatment abandonment by patients. And 78% of physicians indicated that prior authorization can at least sometimes lead to patients abandoning recommended courses of treatment. I think the most common scenario we sometimes think of is in the prescription drug world, that if a patient goes to a pharmacy and the prescription's not immediately ready because a prior authorization was required and no one knew about it until the claim rejected, that patient might never come back to pick up that prescription, which is very concerning. But even in the medical services world, which is, I know, what many of us are concerned with on this in this webinar today, this can be true if a patient's appointment or procedure is canceled and has to be rescheduled because a prior authorization has not been processed or finalized yet. That patient might be lost to follow-up, and that follow-up appointment, that follow-up procedure might never get scheduled. So again, this is very concerning that there seems to be a relationship between prior authorization and treatment abandonment for patients. And then if we look at the next slide, this was actually, I think, the most concerning statistic from my perspective from our 2017 survey. 92% of physicians reported that prior authorization can have a negative impact on patient clinical outcomes. So putting the pieces of the story together, there are the wait times associated with prior authorization responses. This can lead to care delays, it can lead to care abandonment, and those can actually have consequences for patients' health and their ultimate treatment outcomes. So I think this is really concerning for all of us. And then we also wanted to get in our survey some data on the impact on physician practices. So if you go to the next slide, we asked physicians about the burden of prior authorization processes on their practice workload, and 84% of physicians said that prior authorization burdens are high or extremely high. And not only that, if we go to the next slide, physicians are reporting that these burdens are growing, and this is something we hear about a lot from our members at the AMA, that prior authorization requirements have really increased in the past couple of years. 86% of our survey physicians indicated that prior authorization burdens have increased over the past 5 years. And then the final survey slide, which is next here, just has a couple more average stats about prior authorization burdens from the physician perspective. Our surveyed physicians indicated that practices on average are completing 29 prior authorizations per physician per week, and this prior authorization workload for a single physician is consuming 14.6 hours of staff and physician time to complete. So nearly 2 business days per physician per practice to complete the workload for one physician. Obviously, that's a lot of administrative costs in our healthcare system. And because of this workload, over a third of physicians reported that they have staff exclusively devoted to processing prior authorizations in their practice. So again, a lot of administrative costs associated with this process. So I'm going to go actually 2 slides, I think, jump ahead. We also were trying to get some more information about how prior authorization is affecting patients. And, you know, our physicians are reporting it in our survey, but we've been trying to recently gather some patient stories about what their perception is of how prior authorization can impact care. So we recently launched a website, a grassroots website called fixpriorauth.org. There's no www, so just type fixpriorauth.org if you want to check it out. And we have a social media campaign surrounding this as well. And we have both physician and patient-facing tracks, you know, kind of characterizing the experience for both physicians and patients related to this process. And then both of these experiences end with a common call to action for both physicians, other healthcare professionals, and patients too. Basically, share your story. Tell us how prior authorization has impacted your healthcare. And so if you go to the next slide, we are gathering and posting these stories on the website. We have a story gallery, and I encourage you, if you're interested, to go take a look at it. A lot of them are, you know, a little heart-wrenching to hear about how patients' care has been delayed by this process. Here's just one example. The poster wrote, "My daughter has ALS. Her doctor ordered a PET scan of her brain. The appointment was set. Medical transportation was set. Copay paid. The day before the test, the hospital called to say the prior authorization had not been received. My daughter passed away the day before we were supposed to go for the rescheduled test." Again, this is showing how, you know, procedures have to be rescheduled due to prior authorization. Care is certainly delayed, and in this case, obviously there were tragic consequences. That patient never got that care. And then if you go ahead to the next slide, here's another example from a physician perspective. This is sort of getting at the point how prior authorization can kind of interfere in the physician-patient relationship. The physician refers to waiting several weeks to obtain authorizations for MRIs when a patient has abnormal mammogram or pelvic sonogram findings, and how the patient starts thinking that the physician somehow withholding the care and is obviously very anxious to find out what's going on with them when they've had an abnormal test result. So again, the website is gathering some, you know, I think really informative anecdotes about the impact of prior authorization on patients in their care. So you can go ahead, let's go ahead 3 slides actually, we'll skip over the next one. So obviously, you know, the survey data and these stories that we're getting from patients via our grassroots website solidify in our minds at least that prior authorization is something that really could stand for some improvement. And so the AMA, along with 16 other partner organizations, released a set of 21 prior authorization and utilization management reform principles in early 2017. The underlying assumption behind these principles is that prior authorization is going to continue to be used for the foreseeable future, at least. I know that many of our member physicians would like it to go away, and we certainly understand that perspective, but that's not really a realistic starting point, I think, for our conversations with health plans about prior authorization reform. So we assume it's going to be used, but when we talk about ways to make it more efficient, have far less of an impact on patient care, and to reduce costs for all parties involved. So the principles are grouped into 5 categories, including clinical validity, continuity of care, transparency and fairness, timely access and administrative efficiency, and alternatives and exemptions. And if you go to the next slide, you can see the full coalition of associations involved in this work. These groups represent physicians from both state and specialty medical societies, hospitals, medical groups, pharmacists, and we even had a patient group involved, which was great to get that perspective as well. And also, it's been great that since the documents released in the beginning of 2017, we've had over 100 other organizations sign on as supporters of these reform issues. So if we go to the next slide, one thing I was just going to highlight in particular for this audience is that obviously the 21 principles cover a lot of different topics and categories, but I think with course focus on workflows and electronic transactions, it's important to note that the principles do address the issue of standard electronic transactions and say that utilization review entities should support the standard electronic transactions for both pharmacy and medical services prior authorization. So that is part of the reform charge in our principles document. And we go to the next slide, an important point I like to make about the principles was, the end goal was not to post this document on our website and say, okay, we're done with this. That was just the starting point. And frankly, the real work has been ongoing since the principles were publicly released in 2017. The point was to spur a conversation, and hopefully a meaningful conversation about ways that we can all work together to improve prior authorization so we don't have care delays, so that the mother talking about her daughter not getting an MRI before she ended up passing away, that those stories go away, right? And so we've used these principles as a way to jumpstart conversations with health plans and benefit managers about ways we can work together and agree to reform and improve this process. We also have, introduced them to state legislative bodies as things to consider working into their legislation on prior authorization reform. They've been shared with accreditation organizations, and also they've gotten a decent amount of media attention as well in the past year and a half, so that's been great. And then if you get to the next slide, I'd say a very important outcome of the release of the principles was a conversation between national provider and national health plan associations about prior authorization reforms using those 21 principles as a starting point. So a little over a year ago, the 6 organizations listed on the top of this document with their logos and the first bullet in the slide, the American Medical Association, American Hospital Association, Medical Group Management Association, and American Pharmacists Association, on the provider side, got together with the 2 major national insurer trade associations, America's Health Insurance Plans, or AHIP, and Blue Cross Blue Shield Association, to discuss how we can work together to encourage reform in prior authorization processes. And, we started with the original principles document that the provider and patient groups had developed and, talked about what we could agree upon as important reforms in this area. And so the outcome of those discussions was the release at the beginning of this year, so January of 2018, the consensus statement on improving the prior authorization process. So similarly to the original principles, the document is grouped into 5 buckets, and you'll note some common themes, goals of improving transparency and communication around prior authorization requirements. Often we hear from physicians that the first major challenge involving prior authorization is knowing if you need prior authorization in the first place for a particular service and patient. So improving the ability of both patients and providers to access that level of detail and specificity about prior authorization requirements, protecting continuity of care, and automating the process to make it more efficient. And then certainly from our perspective, the first 2 items listed there, the selective requirements to reduce volume of providers subject to prior authorization and regular review of services and drugs requiring authorization, are really important points as well. These parts of the consensus document are getting at trying to reduce the overall volume of prior authorization requirements. We think this is really important. A lot of our discussion today is going to be about automation, and that's a very important part of this pie, but we think that it's also important to keep in mind that even if we made this process completely automated and was working well, we still would want to try to reduce the overall volume of services and drugs requiring prior authorization, because even the best possible scenario, care is going to be delayed at least somewhat. So again, being judicious in applying these requirements. You can go to the next slide. And so one thing, again, I will highlight for this particular audience was that last bucket dealing with automation. And so we have both provider and health plan associations agreeing that it's really important for all of us to work together to support the standard electronic transactions for prior authorization, whether they be the X12 transactions, the X12-278 for medical services prior authorization, or the National Council for Prescription Drug Programs electronic prior authorization transactions for prescription drugs. And then also encouraging adoption of electronic attachment standards to support the standard exchange of clinical documentation, and then also encouraging all of the intermediaries that are very important that both health plans and providers rely upon to communicate with each other, whether they be vendors or clearinghouses, to also support these standard transactions. We all need to kind of get in the same boat and let the ocean rise around us to make this work. So we very much view this as a collaborative process that we all need to sign on board to support. Go to the next slide. And I'll just briefly close by saying that, and you can skip this too, it's just making the point that we all need to work together, basically. Jump to the next slide. Everything I just talked about is available on the AMA website or on our grassroots website as well. So if you're interested, you can take a look at those documents. And I think we're saving questions to the end, but my email is available in the slide deck. If you wanted to reach out individually, I'm happy to answer questions as well. So with that, I will pass the baton back to Jessica. Thanks, Jessica.
Thank you so much, Heather. That was very informative. We really appreciate you being with us today. And now I'd like to welcome our next guest speaker, Stephanie Braunschweig from Athena Health, who is representing WEDI today. Stephanie, thank you for joining us today.
Thank you, Jessica. Hello, everyone. As mentioned, my name is Stephanie Braunschweig. I am one of 3 co-chairs on the WEDI Prior Authorization Sub-group. What I'm going to talk to you about today is I'm going to go over what WEDI is, how WEDI operates, what we're doing around prior authorizations, and how you can get involved. Next slide, please. So WEDI is the Workgroup for Electronic Data Interchange. It is a nonprofit organization focused on the use of health IT to improve healthcare information exchange. The group focuses not only on clinical information exchange, but also on healthcare financial information exchange as well. In 1991, WEDI was named in the HIPAA legislation as an advisor to the Secretary of Health and Human Services. WEDI members span across industry, include providers, vendors, health plans, clearinghouses, and government regulators. WEDI's differentiator is that it focuses primarily on the high-level information exchange workflow and not on the details of what will be exchanged and the transmission methods of the information. Transaction and transmission details are the purview of other industry groups such as X12, HL7, CAQH. And CAQH will speak a little bit more later on. WEDI focuses primarily on workflows and high level, and due to the fact that there's a variety of stakeholders, there's a variety of perspectives on the various information exchange. Next slide, please. So how does WEDI work? Health information exchange areas are broken into work groups, and if an information exchange area is large enough, there are sub-work groups. Some examples of work groups are payment models, security and privacy, telehealth, care coordination, and the list goes on. Prior authorization is a sub-work group under the data exchange work group. To participate in a work group, members join regular calls. Calls vary depending on the work groups. Calls can happen as frequently as once a week when a work group is getting started, or bi-weekly or monthly once a work group is up and running. It just depends on how the work group gets organized. Calls are hosted by chairs and co-chairs who facilitate the conversation on the call and put together the deliverables that are being discussed. Callers are members that volunteer their time, and anyone can join as long as they sign up on the website. WEDI also hosts conferences quarterly that include presentations led by industry experts that gather stakeholders from across the country to listen and discuss various topics. Next slide, please. So the prior authorization sub-work group is a work group under the data exchange section within WEDI. It hosts group meets bi-weekly for the purpose of developing a white paper to drive the adoption of the Health Services Review transaction, which I'll speak a little bit more about that transaction on the next slide when we get to it. The white paper outlines the various prior authorization terms and workflows for various stakeholders. It identifies barriers to adoption and develops best practices of each stakeholder to overcome each barrier. Next slide, please. So the Health Services Review Transaction, otherwise known as the ANSI X12278, and ANSI stands for American National Standards Institute, is a standard electronic transaction that has the ability to put a prior authorization on file with a payer and to check the status of a pending prior authorization request. The transaction is partially HIPAA mandated, but data has shown that the industry adoption has been poor due to various challenges. One of these challenges is the lack of consensus from various stakeholders on how to implement the transaction in their workflows, which is one of the primary things which the white paper is trying to address. Next slide, please. The subwork group meets bi-weekly on Tuesdays from 1:30 p.m. to 2:30 p.m. Eastern Standard Time to walk through various parts of the white paper as a group. We've got regular representation from payers, vendors, providers, and some TPAs and TPA meaning third-party administrators on the calls that we have. What is unique about this group is that we do our best to come to a group consensus on what challenges of the Health Services Review transaction are and the best practices to overcome them. What this means is that every voice is heard, no matter who the stakeholder is. We try not to focus on one stakeholder more than any other. And as long as people are speaking up and attending, we do our best to accommodate as many opinions as possible. Which brings me to my last slide. If you're interested and would like to participate, please go to www.wedi.org and sign up. The Prior Authorization Sub-workgroup is located under the Data Exchange section, which you can look at the top of the website. We hope to hear everyone on the call. Now back to Jessica.
Thank you, Stephanie. And before I introduce our next speakers, I want you to know we've received a couple of detailed questions about membership in the PA sub-work group and whether there are fees to join the sub-work group. And I think probably a lot of that information is on the website, right, Stephanie? If people want more detail about the PA sub-work group.
Yep, everything can be found on the website there.
Great. Thank you so much for your presentation, Stephanie, and we will see you at the national conference next month. And now I'd like to introduce our next speakers, Rachel Goldstein, who's a manager at CAQH Core, and our guest speaker, Rhonda Starkey from Harvard Pilgrim Healthcare. Take it away, Rachel.
Great. Hi, everyone. It's good to have you all on today and to be accompanied by our guest presenters here. Why don't we start off by talking a little bit about CAQH Core and how our work fits into the effort to move the needle on improving the prior authorization process. So for those of you who may not be familiar with CAQH Core as an organization, we serve as an industry-wide facilitator to create and encourage adoption of healthcare operating rules that support underlying standards and accelerate interoperability and really align administrative and clinical activities across providers, plans, and patients. We have about 130 participating organizations. I'm sure that some of you on the line today are affiliated with some of those organizations. Includes provider organizations, health plans, government agencies, associations, and standards development organizations. And our effort, our vision is really all around driving a trusted, simple framework that evolves and aligns with market needs. So we have 4 phases of operating rules to date, and you can find detailed information about that on our website. And the other thing I should mention that might be of interest is that we are designated by the Secretary of Health and Human Services as the author for federally mandated operating rules under Section 1104 of the Affordable Care Act. And we also develop voluntary operating rules that are really guided by industry and market interest. So specific to PA, our core vision for PA is to introduce targeted change to really propel industry forward in a pragmatic way towards a process that is more efficient and reduces administrative burden on providers and plans, and ultimately gets to that component that Heather spoke to of enhancing timely delivery of patient care. Our fourth phase of CAQH core operating rules really tried to get at some baseline foundational requirements that would help with the prior authorization process specific to that standard 278 transaction that Stephanie alluded to. So some highlights there. You'll see on the screen connectivity requirements that facilitate exchange, real-time and batch processing of prior authorization requests, that acknowledgement of receipt of a prior authorization request, and responses within a specified time frame to let the provider know that a request has been received. So at CAQH Core, we continue to develop operating rules to move the needle on that PA process, and we'll get into more depth today about what those latest developments are. So how do we go about doing this? Just a quick couple of process slides. Here you'll see various phases of how we get through the rule development process, and you'll see different buckets of groups underneath each. I should mention that our 130 participating organizations comprise these different groups, and there's various levels of governance and checks and balances throughout the process. But the overarching framework is that we're continuously identifying opportunities by which an operating rule or a business rule could minimize ambiguity and bring some efficiency for the industry in a various area. So in this case, prior authorization. That's usually done earlier on with a smaller advisory group. And then once we have some options that we've thoroughly researched and have been guided by those organizations that volunteer their time, we send on those options to either the rules work group or the technical work group, which convenes these smaller subject-specific groups. So in this instance, our prior authorization subgroup, which is active right now, to fully develop the draft of the requirements that take the ideas that are formed in that identification stage to the next level. There, as you can see, that second layer of due diligence to review the drafts that the subgroups do at the top, where you see the rules and the technical work groups. So we'll talk a little bit more about, if you're interested in plugging in, how we can do that later. I think it's on our last slide. But the other thing to note on this slide that I think is important is we continuously maintain and enhance these rules. Some of the rules in our published rule sets are federally mandated to be regulated, but we also continuously pulse industry to understand how market needs are evolving and really think through how do we make sure that our rules continue to support businesses out there. Next slide. So when we first started scoping the prior authorization operating rule opportunities, there's, as our other guest speakers have spoken to, I mean, there's a world of possibility in terms of where you can focus to mitigate a lot of the challenges that crop up in the process. And really, as you look at how operating rules can fit in, we can see operating rules as solutions for closing gaps in parts of the process that are more manual and less automated. And so when we started a couple years ago looking at some renewed options by which to further scope into potential rules, we convened that advisory group that I mentioned. There's about 5 or 6 organizations that included a provider, health plan vendor, and government representatives. And they started with a list of about 15 opportunity areas that were cultivated via a thorough review and analysis of that X12278 standard technical report type 3 document, public comment and testimonies submitted to NCVHS, and industry forum discussions and initiatives, as well as extensive industry surveys and subgroup discussions through CAQH Core over the course of many phases of operating rule development. So we had a lot to work with. And this advisory group helped us narrow it down a little bit to understand which opportunity areas could be addressed best via operating rule development. Once the advisory group had applied the findings of a broad environmental scan, which we conducted to validate the areas that we had identified and also gain a much deeper understanding of some of the pain points. So once the advisory group had applied those findings to the opportunity areas and funneled the opportunity areas through a rigorous evaluation criteria process, the group suggested that some of these opportunities get passed along to the prior authorization subgroup for actual requirement development. So the ones that really rose to the top, and Rhonda Starkey will get into this in a moment, but the ones that really rose to the top related to enhancing data content requirements for the standard HIPAA-mandated 278 transaction, as well as thinking through what are the options to standardize a prior authorization request and response, regardless of the modality of submission. So regardless of it being the 278 standard or via another submission method. So those are the two items that really rose to the top. So over a course of we've had 11 calls and we're about to wrap up our subgroup work, at least 7 surveys that we've had and robust discussion on those calls. The subgroup has, and I should mention there's over 50 organizations involved, the subgroup has developed 2 draft rules that will now get passed on to the rules work group for that second layer of due diligence. So I think that's enough of a process overview for all of you, and I'll now hand it over to Rhonda. Again, she's the Director of E-Business Services at Harvard Pilgrim Healthcare, and she also co-chairs our CAQH for Prior Authorization subgroup, and she'll walk through some of the detail in our draft rules.
Thank you, Rachel, and good afternoon to everyone. Thank you for joining us. As Rachel said, we did want to do a quick review of the process and status of the CAQH core prior authorization operating rules work that is being done. We view that the phase 4 core operating rules set the industry expectation for how the prior authorization transaction was exchanged. It set rules for timeliness and connectivity rules, infrastructure things. The phase 5 core operating rules that we're working on now, including the prior authorization 278 request response data content rule and the prior authorization web portal rule, we hope represent a step towards a less manual, more timely, and more uniform and consistent prior authorization process. Through research and prioritization efforts, 2 opportunity areas rose to the top. And those 2 were, first, strengthening the information included in the prior authorization request and response so that we could enable a more efficient and effective communication between providers and plans. And second, to simplify the process to initiate a prior authorization request, specifically working to standardize the information asked for on a prior authorization request. The subgroup considered many different approaches to solving these pain points. The requirements you see on the slide are the result of straw polling, feedback collection, and a lot of robust discussion at the sub-work group meetings. An overarching goal of these rules is to enhance standardization and continue to promote industry familiarity and use of the transaction standard. Key items of the draft rules are to first standardize the use of codes to communicate responses to providers. And those are the responses that notify providers of errors or next steps that can be done. In doing that, we believe that strengthens the usability of the 278 across the two groups of providers and payers. And second, to standardize the data field labels on prior authorizations that are currently not using standard data elements. So when you see prior authorization forms in web portals and forms, most requests are submitted and they use their own terminology. We are looking to apply standards of the 278 to these web portals as a method for a path towards standard transaction use, so that you start using those with your prior authorization forms and web portals, and then it's easier to translate those into a 278. The Phase 5 core operating rules will allow the industry to focus its resources on key areas of the prior authorization process that can most benefit from automation and development of systems and applications. These efforts build momentum to a fully automated adjudication of a prior authorization. If we look at the next slide, we talk about the Phase 5 request response data content rules target one of the significant problem areas in the prior authorization process. That is, that requests are pended due to missing or incomplete information, primarily missing or needed medical necessity information. The enhancements, we look towards reducing the unnecessary back and forth between providers and health plans and enable shorter adjudication timeframes and reduce staff resources spent on manual follow-up. The rule reduces barriers to adoption by first strengthening the data submitted by the provider, including patient information and the communication of next steps by the health plan. Second, easing the burden of interpretation on the provider by standardizing code use through uniform use and requiring display of code descriptions, including codes used to flag errors, codes for the next steps, and additional documentation that is required to provide medical necessity information. Also, allowing for more efficient review and adjudication of requests by focusing on key aspects of the prior authorization process that can most benefit from systems and application development. On the next slide, we talk about the Phase 5 prior authorization web portal rule, which we look towards aiding in building that bridge toward overall consistency for the prior authorization request and response by addressing fundamental uniformity of data field labels, ensuring the confirmation of the receipt of a prior authorization request, and providing for system availability. The rule reduces administrative burden and encourages the path to automation by first requiring use of the X12 version 5010-278 request and response T3 or implementation guide names for the web portal data fields. And that supports tying in and linking the web portal to the 278 transaction. Also, the rule is looking to require system availability reporting and confirmation of receipt of the prior authorization submission, so that we can enable, there can be predictability for providers on when they should expect and what they should expect, and reduce manual follow-up. Also, look to adhering to the requirements outlined in the Phase 5 core prior authorization request response data content rule when the portal operator maps the collected data from the web portal to the X12 278 request and response transaction. Again, it's linking the actionable items from the web portal to the 278 transaction. And last, looking to reduce variation in data elements so that we can encourage, we can ease submission burden and encourage technology solutions to minimize the need for providers to submit information in multiple ways. Next, I'd like to do a quick review of the timelines for prior authorization on our next slide. The Prior Authorization Advisory Group launched in the fourth quarter of 2016, in which the environmental scan was conducted and refining the rule opportunities and identifying those was made. Following the CAQH Core's established operating rule development process, our data content sub-workgroup will reach the point next month where we will hand off the draft rules we've developed to the rules workgroup for their review. This group is forming now, and as Rachel mentioned, we would both encourage all of you to participate, invite colleagues to participate. I will be actually helping to co-chair in that one as a coordination between the two efforts. And you can see that in this slide as the second purple line is our work group will be finishing up just as we start Q4, and we'll be handing off to the rules work group on the last purple line. After the rules recommendations have been handed off and sent to the rules work group, the CAQH core certification and testing subgroup will also convene so that they can begin drafting the test suite for the rules. That group then passes their draft test suite over to the technical work group to review, and that will happen with the testing, certification and testing subwork group will start in Q4 as well, and will go through the first quarter of 2019, and the technical work group will review in first quarter of 2019. And again, all of these groups are open for you and colleagues to participate in. And then last, once the rules and technical work groups finish their reviews, CAQH Core will hold an all core participant vote. And that is that all core participating organizations that are implementers will vote on the rules. And finally, the rules will need to be approved by the CAQH Core board, and that is made up of our multi-stakeholder industry leaders. And we expect these last two steps will occur in the second quarter of 2019. And all of that, of course, is pending what happens with final approval of rules as we hand them off and start working our way down through certification testing and on to voting. And last slide, next, is, again, encouraging folks to participate. The core groups are open to CAQH core participating organizations. If your organization does not currently participate, please reach out to core. Everyone would love for you to have you join. The three, as we mentioned, the three main work groups that are now open to join are the rules work group, which will be starting in Q4. That group will review the draft rules that the subgroup has developed, the data content and prior auth portal subgroup has developed. The second group will be the certification and testing subgroup, which will develop the certification and test suite for the operating rules. And then the last group is the technical work group, which will review the certification and test suite. And the note that CAQH Core makes is you can have a really big impact by helping your organization become certified in phases 1 through 4 of the core operating rules. We now have 78% of commercial lives or in health plans that are core certified. And with that, I'll hand it back off to Jessica for polling.
Thank you so much, Rhonda. I really appreciate your presentation, and that last slide you described is a perfect segue to our polling question for this webinar. Let's go ahead and launch the poll. But we would like to hear from you and what efforts you might be interested in engaging with us. For the first three options, the various work groups that you could participate, you do need to be a core participant in order to join those efforts. So if you're interested in being part of the Phase 5 rules work group, the technical work group, and the certification testing work group that were just discussed, feel free to check those boxes. If you were not a core participant, but you would like to engage in these efforts or learn more, check on that fourth option and we'll contact you with some more information. And finally, we are spending some time thinking about ROI and maybe piloting some projects to try to assess and measure that. So if you're interested in being a part of that, please check the fifth option. We are not going to share these results, but we will be contacting you with more information. I'm just going to leave that open for a few more seconds so to give people time to engage with us. We really we do walk the walk when we talk about being multi-stakeholder and wanting consensus. We really want to work with as many industry partners as possible. So I think we can go ahead and close the poll. Thank you so much. Some of the answers were very encouraging, so we will be getting back to some of you. And now we have time for Q&A. If you haven't already submitted your question, please do so on the questions panel on the dashboard. So let's get started. The first question is there a mandated time for insurance response post-PA, post-prior authorization? Rachel, you can take that question?
Yeah, sure. We get this question a lot, and it's a nuanced answer. I think if you think about the entire prior authorization process end to end, when you think about that response, I think there's two types of responses that providers really want to receive, and this is what we've heard over and over on our feedback. And one is that we got your prior authorization request and we're working on it, or this is what you need to do to make it more complete. And the second is a final determination, that final response, the one that the provider can really take and say, okay, this request for prior authorization of a medical service or referral was denied or was accepted. So something that can really not delay that patient care any further because there's an answer that provider can work with. Obviously, a lot of interest in both. So I think an immediate answer is that there's no federal requirement. There's no mandated federal requirement for response time. There is the Phase 4 core operating rules do set response time requirements, and these rules are voluntary and available for implementation now. They do set response time requirements for that initial response. It's 20 seconds in real time, and then third business day for batch via the 278. In terms of a final response, this is a concept that has come up quite a bit in industry discussion across events and within our CAQH core participating organizations and workgroup efforts. It's something that we're committed to looking more closely into to see where we can gain some additional consensus in industry about a potential requirement for maximum time frame for a final determination of a response. Quickly, I'll also just mention that the AMA does put together a really nice resource that compiles and summarizes where the states have made some movement on various prior authorization requirements within their legislation, and there is some information in there regarding which states have made have developed laws on this topic.
Thank you so much for that answer, Rachel. The next question, I think, is a question maybe more appropriate for Heather to address. And the question is, do you foresee the prior authorization process will be removed as part of the care continuum? You want to take that question, Heather?
Sure. And, first of all, and I say this with a little levity, but with some seriousness too, certainly from our perspective at the AMA, from a physician perspective, we would say, yes, we certainly hope so because of the burdens, and also from the patient perspective, right? I think we all can agree, no matter what stakeholder group we're coming from, that we all deserve better as patients and, better than having our care delayed in the way that we've been discussing today. But I think there are some things, certainly in some of the AMA's work and some of the conversations going on around the consensus statement that point to that there might be other ways to get around, judiciously and respectfully using our limited resources in healthcare, but doing it in a way that does not burden providers or patients. Certainly, as we think about the increasing and accelerated movement towards value-based care and risk-based payment contracts in our country, it seems reasonable to believe that as providers take on more risk in their payment arrangements, they would not be subject to prior authorization requirements because already they would be quite motivated to contain costs. So moving away from fee-for-service payments to value-based, risk-based contracts might be a movement in that direction. It's something certainly we support and is one of our principles, as a matter of fact. And then also looking at, some more innovative ways to, again, perhaps address appropriate use of different services, but doing it in a way that's less burdensome, that's embedded in the physician workflow, looking at, innovative works and technology going on with clinical decision support mechanisms, perhaps looking at using those kind of tools in lieu of prior authorization, looking at appropriate use criteria, those sorts of things. And again, just exploring other ways to go about, carefully and judiciously using our resources, but not doing it in a way that limits patients' access to timely individualized care and doesn't burden physicians and their staff.
Thank you, Heather. We received a question wanting a little bit more information about the environmental scan that we developed that helped inform the operating rules. Rachel, can you share a little bit more information with the group?
Sure, yeah, and I'll do my best to be quick so we can get to some other questions. So with the environmental scan and this, anytime CAQH Core launches a new operating rule development effort, this is a standard part of our process. We're currently doing an environmental scan on attachments right now, additional clinical documentation in anticipation of developing operating rules later on. So this is a pretty standard part of our process. Essentially, we do kind of a multi-pronged approach where we develop survey instruments, interview guides, and also do to the various stakeholder groups. So the questions are different to the various stakeholder groups to make sure we get a multi-stakeholder insight. And we focus heavily on identifying specific barriers to automating parts of the process or to adoption of the electronic transaction in general. And then we also look for potential opportunities or solutions. So part of the scan also involves a participant-wide survey that takes a bunch of the different opportunity areas that have been identified that are potential, can potentially mitigate the biggest pain points that have come up again and again. And we do that polling to understand on a couple different levels in terms of impact and priority and urgency, kind of how they all pan out across the various stakeholder groups. Another thing that I should mention is once we have all the pain points addressed, we do an analysis to understand across, we had over 100 entities participate in this environmental scan, a real cross-section of folks, and so we do both qualitative and quantitative analysis to understand where the patterns are. We do any follow-up that's needed to close information gaps, and having the work groups along the way also helps validate a lot of what we found.
Thank you, Rachel. Another question came in asking whether these operating rules for PA apply to pharmacy.
Oh yeah, great question. Actually, we get this question a lot, and there is the short answer is no, they do not. There is another organization called the National Council for Prescription Drug Programs, and they're the standards organization that has the electronic prior authorization standard that is specifically for retail pharmacy. So our CAQH Core operating rules do not apply to retail pharmacy. Thank you for that question.
And I think we have time for one more question. And the question came in, so what happens when a prior authorization for a medical service doesn't match the claim?
Yeah.
So can you address a scenario like that?
Sure. So, and Heather, feel free to chime in, but basically there's oftentimes, and we found this in our environmental scanning, and I'm sure that the AMA has seen it in their research as well, that a prior authorization request for a specific medical service, for example, may be approved, but then the provider goes in to perform the service and performs based on their medical opinion and what seems right for that specific patient. They perform an additional service or a different service that didn't necessarily go through a prior authorization process. This is really, really common and just happens in medical care and is part of that patient care reality. And so there's this nuanced challenge of how do you deal with that if it was a service that maybe required a prior auth but wasn't pre-certified. So I think a quick answer is that the 278 at least does allow for submission of multiple procedure codes. So that doesn't fix everything, but if a provider does feel that there may be that window of a little bit of uncertainty or want a little bit more flexibility later on, there is an opportunity to submit multiple codes. I should note, for just due diligence, this doesn't necessarily always address the challenge of even if a prior authorization is approved, there are still circumstances where a claim can be denied and it results in, jeopardizes provider reimbursement and impacts the patient in terms of their expenses. So again, we can't solve everything today, but it is something that we're really aware of. And as we look at, the revenue cycle in general for healthcare administrative transactions is something we need to continue to think about as an industry.
Hey, it's Heather, and I'll just jump in really quickly and basically kind of reiterate a couple of things that Rachel just indicated. But yeah, this certainly is a huge concern from the provider perspective. You obtain a prior authorization, and then at the end of the day, the claim is not paid for various reasons. Sometimes, as Rachel indicated, it could be that the exact procedure is slightly different than what was approved. This is often the case with a surgery. You get into there with the patient, you're doing surgery, and things change a little bit, right, based on kind of conditions on the ground in the operating room. Or there's other cases where something other than the authorization criteria end up the claim being denied. Like suddenly the patient might no longer be covered by the plan. There might be limits in the number of types of service that can be provided in a certain period of time, things like physical therapy. So there are other policies in play that weren't part of that authorization process that ended up in the claim being rejected. So I think, obviously it's a big concern. CORE is, as Rachel indicated, sort of try to look at this and some of the issues of being able to submit multiple codes on a request and, how can that help with part of the problem. Certainly it's an issue that we address in our 21 principles. We have a principle saying that, an approval should be binding on the plan for 45 days. So the provider's not left, with an unpaid claim on their hands. And then also, and not to jump in on top of Stephanie, but the WEDI sub-workgroup has also discussed this as well. And, the concept of getting multiple service codes approved, possibly with a request to cover a related services that might be provided depending on what the situation is during the actual procedure when it's happening. And then also, the idea of, recommending that plans actually check other things other than just the authorization criteria, like eligibility, like other medical policy requirements when they are providing the authorization response, so the provider is aware of other things that could potentially interfere with payment of the claim. So it is, it is a complicated issue, but certainly multiple groups are looking at this. And so I would just say to the person who asked that question, your concern is very much heard, and people are trying to find a good solution to your question and problem.
Thank you so much for that, Heather. I appreciate it. And we are unfortunately out of time. I'd like to thank our speakers as well as our attendees for joining us and sticking with us even after the 4 p.m. hour. If we did not get to your question or you have additional questions, feel free to email us at core@caqh.org. And with that, have a great rest of your day.